Hi, everyone. Welcome to our session on the promises and challenges of long-acting injectable antiretroviral drugs. This is meant to be a discussion session with a meet the professor type of mode. So I'm not going to do a long presentation about data. You've heard some of the data already in Dr. Gulick's discussion this morning. And I'll be also reviewing some of the new long-acting formulations in my talk in the next hour. So let me just go right to my slides and do a little bit of an introduction for this session, talk about our goals and objectives, and then we can open it up for discussion with all of you. So thank you for joining our session today. We greatly appreciate having you with us. And I'm introducing myself. I'm Constance Benson. I'm a professor of medicine and global public health at the University of California, San Diego. And I'll be moderating this session and engaging in your questions and responses. So the goals of this workshop are listed on this slide here. We plan to talk about the potential benefits of long-acting injectable antiretroviral drugs for treatment and prevention of HIV infection. We'll talk a little bit about the challenges in implementing treatment with long-acting antiretroviral drug regimens, and hopefully have some time to explore your suggestions and comments about ways to address some of these challenges. I think we all know that the data from the Latte, Atlas, and Flare studies, some of which you'll hear in final analyses later this morning, have all shown that Cabotegravir plus rilpivirine long-acting, when given in an injectable mode, either every 4 weeks or every 8 weeks, has had comparable activity to standard of care regimens, mostly compared to dolutegravir, abacavir, and tenofavir. And we also know from clinical trials that every 4-week and every 8-week injections are comparable in terms of their ability to maintain viral suppression after achieving that with a potent antiretroviral therapy regimen. HPTN 083 also released results this year showing that cabotegravir long-acting, when given intramuscularly every 8 weeks, was actually superior to tenofavir and FTC for pre-exposure prophylaxis. So all of the results of these trials are leading to the point where we hope to have these available for clinical use shortly. We do know that long-acting cabotegravir and rilpivirine injectable and oral agents were filed with the FDA for approval. The FDA in last fall deferred their approval, not because of issues related to the activity of these regimens, but more related to assurances about the manufacturing ability and some of the manufacturing procedures. And they asked for further clarification from the company about how this was going to be accomplished. So we hope that all of those issues have been addressed and we'll see FDA approval shortly. So some of the potential benefits that have been outlined in many talks, I'm sure you've all heard over the last few years, are issues related to patient convenience, patient satisfaction, tolerability, maybe improved viral suppression because an injectable regimen may be more forgiving in terms of people not missing doses, and that may have the potential for decreased risk of drug resistance. We don't yet know the full costs of these regimens, and sometimes the drug costs themselves are not necessarily all the costs that are entailed in putting together a plan for implementing long-acting antiretroviral drugs. There are a lot of challenges also, and I think most of those challenges have to do with the implementation of these regimens in clinical practice. They require, obviously, the appropriate supplies for dispensing the medications in intramuscular formulations to patients. They require staff training, patient education, a determination in your own clinics whether you're going to be the ones to administer the drug or whether you're going to teach patients how to do that. What's the best way to monitor response to therapy and monitoring overall for safety and efficacy. If patients stop the medications or don't come back for their injections, is there a safe way to cover the long tail of these drugs in pharmacologic measures? And if patients have to go off long-acting agents, what are the best second-line ART options? And I think these are all potential challenges in using long-acting drugs. So those are really my introductory remarks. We can come back to several of these questions as we go along, but I really want to emphasize that this session is meant to be open to questions, comments, and your own thoughts about the potential benefits, the potential challenges, and hope that we can share knowledge among ourselves for how to do this in clinical practice. So sounds like there's a comment in the chat room that there's a lot of microphone feedback. I don't know if our PSA people can fix that, or PSV. I'm sorry if I'm getting your acronym wrong, but any thoughts on fixing the microphone feedback that's occurring for the participants? Hopefully everyone who's not speaking is muted, sometimes not having the microphone. Seems like my microphone is okay. Seems like other people are getting feedback is better. Okay, so I guess the comment is that's local. So let me just look in the chat room, and I'll start with one comment that someone's posted already. And if you'd like to speak, you can just open your microphones, or you can wave to me and I'll unmute you. The comment is that mentioning both not just the direct costs, but the indirect costs of these newer agents is something that we always need to consider when implementing these in clinical practices. What do people think about how they plan to use? Let's just open a question up to you all. Are you all planning to use long-acting antiretroviral drugs, injectables in your practices? Anyone want to comment? Okay, 2 people said yes, they are. Once approved, yes. Many patients are asking. Depends on developing systems for delivery. So I think, as I outlined on my slides, one of the major questions for developing systems for how to deliver injectables is making sure you have staff that are trained in how to use them. You've worked out a plan for how to monitor them, and you've got patient education materials available both to educate patients and then a system for determining whether a patient is capable of administering themselves or coming into your clinic to have injectable drugs administered, or whether you plan to use home health services or other types of support services. So anyone want to talk a little bit about how they're planning to implement injectables in their own practice? Okay, we have a quiet crowd this morning, so let me just talk a little bit about what I see in the chat room. So one question says it will depend on insurance as well. Obviously, that's the case for many of us. Long-acting injectables are not currently on a formulary because they're not fully approved yet. One person in the chat room comments on, I'm a pediatrician and young adult provider, so having patients have to be suppressed with an oral lead-in might keep them from using this in many patients. So yes, that's a very good point. Many of the clinical trials thus far have required up to 4 weeks of an oral Cabotegravir, rilpivirine lead-in phase in order to achieve viral suppression. And that can complicate certainly therapy for children, or young adults and adolescents. Another comment in the chat room, I think that long-acting injectables would be extremely helpful for patients who are often difficult to retain in care or have difficulty with adherence. But I also worry about covering the tail and thinking about these people falling out of care after receiving an injection. Any thoughts on ways to address this? How are people thinking about preventing falling out of care and dealing with the tail? Anyone have thoughts about that? Looks like we have a raised hand, so.
Hello.
Hi.
Hi, I wanted to make a comment regarding the use of the injectables, obviously. My comment was that I think what this will do is change the way we deliver HIV care, which of course is one of the major objectives of end the epidemic. That what we're doing right now is great, but it ain't ending it. And in that there probably will be this full cycle back to the importance of nursing in HIV care, which has always been there, but sometimes not credited for its important influence on the care of patients and moving away from just antiviral therapy, but all the other resources that can be provided during a time where we're only getting paid to give an injection, but we're educating, we're supporting, we're counseling, all these other things that we don't get paid for, and especially nursing doesn't get paid for. So that's my comment.
I think those are very good comments. We all have those experiences. It's hard to keep staff fully supported in a lot of our clinical practices when a lot of the care we have to provide isn't compensated or not compensated adequately to support that staff. I think from my own perspective, I think we will need more nursing care to support injectable agents, depending on how many patients you think you're going to have on injectables. There's been some research work on pharmacies being able to, like CVS, Walgreens, and commercial pharmacies, being able to administer long-acting injectables and observe and monitor those for patients. What do people think about using a commercial pharmacy rather than having it administered in your own office? Okay. Let me just go to the chat room. We need pharmacists to assist in making sure that clients are receiving injectables on time, as many clients access the pharmacy more often than the clinic. I think that's a very good point. I think another comment is there are a lot of good clinic models for long-acting injectables used in other capacities. Also a very good point. Depo Provera or Vivitrol for tracking patients and helping coordinate care. Those are also resources we can draw from in transitioning patients to injectable agents. Another comment, not every patient will be a candidate for this, as we already have patients who are non-compliant with oral therapy and are likely to be non-compliant with injectables. I think that particular issue is one of the key concerns and challenges that many of us have about using injectable drugs. How do we identify who's the best candidate for these? And does being non-compliant with oral therapy automatically translate to being non-compliant with injectable therapy? I'm not sure. We don't really have long-term follow-up in any of the clinical trials. I know that the AIDS Clinical Trials Group Network, in a clinical trial being conducted right now, is doing or implementing long-acting injectable therapy in people who have been out of care and are returning to care and are in that high-risk group of being non-compliant with prior therapy. We don't have results from that clinical trial as of yet. But I think, again, one of the major barriers to that approach is the requirement for the phase-in or the oral lead-in phase of the injectable agents, getting people fully suppressed before transitioning to injectable drugs altogether. And that's clearly been an important issue in the clinical trials. One of the comments in the chat room, I worry slightly about stigma. We have more influence on how our clinical providers and staff are trained in cultural competency. We have patients who have variable experiences in how they've been treated by CVS, Walgreens staff, depending on which store they use. So that may be another challenge to having assistance from commercial pharmacies in implementing. There's also other thoughts on stigma being a barrier to long-acting agents. Would someone like to build on that thought a little bit? What the concerns are about stigma with injectable drugs? How about that comment comes from John Weiser. Can you unmute yourself, John, and talk a little bit about your concerns?
So I think that if people aren't adhering to oral treatment consistently because of internalized stigma, having to take a pill brings up feelings that are just not acceptable. So they put the medication aside and don't trigger those feelings. That the same issues will apply to coming in periodically for injectable treatment.
I hadn't thought of it in that way, but you're right. I think stigma is something we have to deal with on every level for people with HIV. Erica, you have your hand up, or you lowered it?
No, I will say, as a pediatric, adolescent, young adult provider, actually, I think the stigma for the shot for a lot of my patients will be a lot less than the pill, because a lot of them, say, just like the prior speaker said, every time I look at my pill bottle, every time I have to take my medicine, it reminds me of HIV, and I don't want to do it. And they have actually been asking me, can I just get a shot for this, for years, long before we even had them in trials. And so actually, assuming we'll be able to use them, but again, we're limited by the having to do the oral lead-in in a patient who's not doing oral medicine well. And I actually have less concern about, because I have patients who will consistently come to appointments, but they don't consistently take their oral medicine. So if they could consistently come to their appointments and I could administer their shots on a regular schedule, I think we'd actually do okay.
That was kind of how I was thinking about it too. So, having the pill bottle in the home and having to take it out every day and deal with the constant reminders seemed to me to be more stigmatizing than just coming to clinic once a month and getting an injection, or once every 2 months and getting an injection.
I'll also add, for our young adults who may be living with friends, living in other places, and they're always terrified their meds are going to be found. Again, this is also another really good solution for them. Right.
So I think those are all very good points. I think it remains to be seen how these things get used more broadly in clinical practice. We can't always replicate in clinical trials how things might be implemented in clinical practice. And so these are, I think, are extremely good points about things that we'll need to monitor and track as we begin to bring these things into clinical practice. Several people are agreeing with you that most of my hardest to adhere patients may do really well with injectable agents. Another comment is having an injection every 2 months may be more forgiving unless you're forgetting to return for that injection because you're not getting a daily reminder to take a pill. So I think, again, that's something that's going to be really key for us to be tracking as clinicians when people come in. Let me go to a couple of other questions. Michael, you have your hand up. Do you want to comment?
Yeah, it's more on HPTN 083, Dr. Benson. Just wondering what the oral lead-in is with oral Cabotegravir. I'm excited about the potential of using it in PrEP more than maintenance. I think it'll have a broader scope in my practice. And I just wonder if you can maybe expand a little bit upon that.
Yeah, I don't want to steal too much thunder from people's lectures, but I was not part of that study and I don't do PrEP, so I don't want to be misleading in my comments about that. But I think you're absolutely correct that if there's an oral lead-in phase with long-acting Cabotegravir for PrEP, that's going to complicate that implementation as well. I think all of us are a little bit concerned about this oral lead-in phase. And I think that PrEP has the promise. I think this has major promise for PrEP. I think we've all struggled, although I'm not the one that does PrEP in our group, are my other colleagues who do the PrEP studies and administer PrEP to our patient populations do struggle with this issue because people have difficulty taking daily oral PrEP or even some of the regimens that we know, on-demand PrEP or 4 days a week PrEP or 2 days before and 2 days after. Those are all complicated things for people to remember. And again, concerns about stigma are constantly raised with that issue as well. So I think coming in, and to me, this gets more into that category that other people were commenting on, Depo Provera, for example. So Depo Provera, frequently used contraceptive, is easy for women to get their Depo Provera injection, not have to worry about it forever. And you can easily see people getting PrEP having the same kinds of ease of use and tolerability and favorable reactions to that. I guess the question always that comes to mind, and this is being raised by a couple of the people in the chat room, are the issues with resistance. So if someone happens to get infected on the tail end of that every 8 weeks of Cabotegravir injection, what does that mean for resistance? I think what we saw from HPTN 083 is we did not see resistance occur, and it was very effective. But I think with people who sort of fall out of care again and lose the tail or lose the consistency in coming in for injections, that does raise concerns. Anyone else have comments about that? Please feel free to raise your hands or just chime in and unmute yourselves. I'll start with a little, yes.
Do you foresee them having the oral lead-in go away at some point?
You know, it has not been talked about, but I think there is a move in some of the clinical trials that are ongoing if someone's already fully suppressed on antiretroviral therapy and you're making a switch over to, and that's one of the things that I'm going to be talking about in my lecture in the next hour, is one of those studies. They didn't eliminate completely the oral lead-in, but I think that is one of the potential moves. If someone's already fully suppressed on a regimen, is it possible to switch over to these long-acting injectables? I think one of the difficulties, however, is not that we're really trying to get people suppressed on that oral lead-in, but to understand if they're actually going to tolerate cabotegravir and rilpivirine. So it's a similar concept to when you start anybody on any new regimen. You're not entirely sure whether they're going to tolerate or develop side effects or toxicities from that regimen. And one of the complexities with giving intramuscular injections, if they've not had that oral lead-in, so you know that they're tolerating it, is what if they develop an immediate hypersensitivity reaction or intolerance to one of the components of the cabotegravir rilpivirine regimen, or for PrEP in the cabotegravir alone. Then you've got that injection, you've got that long pharmacologic tail there. What are you going to do to manage that toxicity or that issue if you don't know that they're going to tolerate those regimens? So the oral lead-in is more not to get people suppressed, but to understand if they're going to tolerate the two drugs or the one drugs. So one of the questions raised in the chat room is, what were the rates of not tolerating cabotegravir in the trials so far? Well, from the data I'm aware of and in our site and participating in these, we didn't have anyone who didn't tolerate them. So I think it's pretty rare. So if, as we begin to implement these regimens in clinical practice, we see that this is rare, there may be room for moving on to, at least in people who are fully suppressed, switching them over to the injectable without an oral lead-in phase. But I'm not advocating that at this point. I think we just don't have enough data to understand. So let's see, another recent comment in the chat room. One concern I would have is access to injections during unexpected episodes like COVID-19 or other life events. In Michael's clinic, he's found it easy to continue patients' regimens during COVID-19 by delivering medications by mail. But if patients needed to come to clinic for injections, their care may be unintentionally interrupted if they are unable to leave home. Do people have ways of getting around this? I wish I had a good answer for that one. If you all do, I think that would be great. I think the only potential solution to that is if we get to a place with injectable agents that we can teach patients to do their own injections, then that may be a mechanism for dealing with these kinds of life interruptions that make it difficult for them to come in to clinic for injections. I think that's probably a ways away. I don't know how comfortable all of us are going to feel with a patient being able to give themselves IM injections. That's going to take a lot of working with individual patients and feeling comfortable that they can safely do that. So one comment that in response to that would be having home health care might be the answer to that as well. I know that's one of the things, not so much long-acting agents, but we're involved in one of the clinical trials that requires an infusion for treatment of early COVID-19 disease. And in that clinical trial, we're involving home healthcare services to provide infusions in the home. And this may be another stopgap method if you can't have patients come to you, having a home health service go to them. Increasingly, we're working with home health agencies that are willing to go into the home if they have adequate personal protective equipment for people who have COVID-19 and can't get into healthcare. And that's also likely to be the case for people who don't have COVID-19 but can't come into the clinic. So that's another issue. So there was a question about cabotegravir toxicity. Can it be resolved by dialysis? No, to my knowledge now, and I may need to confirm this with other colleagues, but at least in the context of clinical trials, the comments were, to my knowledge, we can't deal with it by dialyzing it. So I'll see what I can find out during the break and make sure I comment about that in my talk. Is there any evidence using long-acting injectables for HIV in persons who are also getting them for schizophrenia? I don't have any experience with that. My only experience with other long-acting injectables is with Depo Provera. Have others in the group used long-acting injectables for treatment of schizophrenia in your HIV patients? Okay, sounds like none of us really have experience with that. So again, another challenge that we would need to work out. There's a question about the forgiveness window around the injection times. If someone needs to come early before injection is due or late. So most of the issues that have surfaced around forgiveness have been addressing the question about coming in late. And in the clinical trials that have been done, when a patient or client knows that they're going to miss an injection or they have to be late or scheduled late, the clients have been given oral cabotegravir, rilpivirine, long-acting medications to tide them over until they can get in for the injectable agent. So if they're at that tail end of that 8 weeks or 4 weeks, whatever regimen you put them on, and they can't get in for another week or another 2 weeks, giving them a short-term prescription with the oral agents so they can tide them over until they can come in is one way of dealing with that issue. In terms of coming early, I don't think you would get into too much trouble with toxicity. I have some PK data to show, but the PK data from the clinical trials, I think if someone came in a week early, that would not be unacceptable. You wouldn't want to give it too frequently. So not 2 weeks, but maybe a week or a few days to a week early wouldn't be a major problem. I don't think you're going to get into trouble with very high concentrations that might lead to more toxicity. So the real strategy is if they have to come late or if they are traveling and can't get in for their injection, giving them short-term oral cabotegravir and rilpivirine LA is the way to tide them over to the next injection. Okay. Comment, again, coming back to costs would be the additional costs of home health services and all of the other things that go into implementing long-acting drugs need to be addressed by HRSA, as additional funding would obviously need to be required to cover these costs. I don't think we have representatives from HRSA on the call today, but maybe we do. I don't know what HRSA is thinking about how they plan to support implementation of long-acting injectables. I think that's another issue that remains to be established. So there's a question from Christine. Do we need to worry about the Cytochrome P450 system? Will we be bypassing first pass metabolism? Yes, you will. But I'm going to show you data in my next talk about the Cytochrome P450 system. And at least in the short-term PK data, or actually it's pretty long-term PK data that have been done when people stopped the injectables in clinical trials, even though these drugs may impact metabolism of other medications, the decline in concentrations seem to be such that they won't likely interfere with your ability to use other drugs that also are metabolized by the cytochrome P450 system. There's another comment that long-acting formulations could be more beneficial in the jail systems and in medicated and MAT centers that are using MAT to support drug-using individuals for treatment, contraceptive centers. So lots of suggestions about dealing with some of the injectable support issues. I'm just kind of going through the chat now to see if there are other questions. So how frequently would you do viral loads or CD4 counts in patients who are adherent to the injection schedule? And how about non-adherence? Do we know how long the tail is? Well, I'll give you a little preview of my next talk. I'll answer the last question first, but you can find detectable Cabotegravir and rilpivirine pharmacokinetic samples out to a year after the last injection. So not in concentrations that are active against virus, but you can find concentrations of drug out to at least a year. In terms of viral loads and CD4 counts, I think we're getting into the stage where once people are fully suppressed and their CD4 counts are adequate, we're not really doing a lot of monitoring. And I think the clinical trial that we're doing in the AIDS Clinical Trials Group Network is moved out to checking a viral load after the first 8-week injection to make sure that patients are still fully suppressed, maybe repeating one more, and then spreading it out to once yearly if people are really fully suppressed on their regimen and are adhering to the injections. What do other people think about that? What's going to be your safety zone for monitoring? Anyone want to comment? Okay, everybody's pretty quiet here. Does that mean nobody has a safety zone? Okay, well, that's something we'll need to think about a little bit. Just checking through the chat room to see if there are other comments I might have missed. Looks like a couple of people. So at least 3 people would like to keep current recommended monitoring 2 to 3 times a year for viral load. And one comment, I'd be fine with yearly, but HRSA requires twice yearly per HRSA grant. So again, this would be something, it'd be wonderful if we could hear a little bit about what HRSA is starting to think about in terms of how they're going to support long-acting injectables. I'm sure they're thinking about these things, but John Weiser comments that in Georgia, the ADAP program still requires CD4 and viral load monitoring every 6 months, although that requirement was briefly suspended due to COVID-19. Others have commented if we're treating this as equivalent treatment, then keep to recommended monitoring. I think others have commented, I think this is a new way to treat HIV. We should be more careful following viral load, but in general should follow standard recommendations. Sounds like the consensus around this point is most people feel comfortable with following standard of care recommendations as they currently exist. I think that's probably a good piece of advice to follow starting off. Obviously, HRSA and the HRSA grants are going to be making a statement at some point about what they're going to recommend and what they're going to require for people when they do get started on these agents. So that will guide some of what gets done in the context of this. I think twice a year, there's another comment in the chat room from Christine, that twice a year is a good period to check on any person who's receiving chronic pharmacologic treatment. Perhaps only labs, but some type of check-in. I think that's in general very true. I think we've learned from a lot of clinical practice experience that people who come in only once a year or twice a year sometimes are a higher risk for being lost to follow-up altogether. Some people need some regular being in touch with their clinical providers to maintain their confidence in the medications that they're receiving and your confidence in their maintenance of viral suppression. And I think at least twice a year is likely to be where most recommendations are going to settle out once you know that they're tolerating the injectable and they're complying with coming in for receiving injections and they're fully suppressed. Kara comments, I think it will take a while to get comfortable spacing out viral load to yearly, but one of the benefits of long-acting agents is that you have an easier way to confirm adherence since you're documenting the injections. And so I think that's a very good point too. And then rechecking more frequently if they're late on their injections. That's also an important point. So sounds like everybody's really ready to get started with long-acting injectables. You've already got the guidance down and figuring out what you're going to do in your practice. What do you all think how are your patients receiving this? Has there been a lot? Sounds like Erica had a lot of patients who were looking forward to getting injectables. What are other people hearing? What's the buzz from your patients? Are people looking forward to this? So Adisa comments, lots of excitement from patients who want this option. Other people saying, yes, their patients are interested. Many are looking forward to it. Lots of patients already asking, lots of patients interested, open to trying it, getting a lot of questions. So sounds like there is a lot of buzz about this. There was one question about FDA approval. I wish I could give you a date. I know we were all anticipating that we might have approval last fall, and that didn't happen. As I commented on in my opening remarks, the reason for the deferral of approval last fall had to do with manufacturing of the regimen and assuring that that the formulations of those regimens were being adequately controlled in the manufacturing process. And I think that the company was asked to go back and readdress some questions about manufacturing issues. And I know that they've been working on this. My understanding is it's been resubmitted for FDA consideration based on some of the data that I'll show you in the next talk. But I don't have a date for you, and I'm hoping that certainly by this fall, I'm hoping that we'll have approval of these agents so we can start using them. Some comments in the chat room, many people are asking, but there's some concern about injection site pain and injection site reactions. And you have all seen these data that virtually 80% of people in the clinical trials have reported some type of injection site reaction. Fortunately, the majority of these have been what we have labeled grade 1 or grade 2, meaning they're mild to moderate injection site reactions, and they resolve within 2 to 7 days. But again, that's going to turn some people off, and depending on their pain tolerance and their ability to tolerate injections. I don't know if any of you have used injectable agents before. I'm sure we've all had injections. Nobody really likes them, I think. But in the context of getting used to them. There is some suggestion that maybe the first few injections have more injection site reactivity to them, and then that attenuates with continued use. I don't know that that will be the experience for everyone. There is a lot, some people comment, there's a lot of pill fatigue out there, and a lot of people may be comfortable moving on to an injectable, even if they're really already comfortable and fully suppressed on their oral regimen. So let me see a couple of, so one comment about FDA approval was this submitted for both treatment and prevention. Right now, my understanding is it's been submitted for treatment. I think prevention will follow quickly. The results of HPTN 083 were very robust, but there's also continuing follow-up in HPTN 083. And there's also a subgroup of HPTN 083 looking at evaluating long-acting injectable Cabotegravir in young adults and adolescents, a group that's of particular importance for PrEP. And so I think it may be a little bit longer before we have it for PrEP. There's also comment here that don't forget about baseline resistance to NNRTIs before you prescribe long-acting Cabotegravir and rilpivirine for treatment. Also a very good point. Most of you, I'm sure, are getting baseline resistance testing before you start people on therapy, and that's obviously a consideration. Baseline resistance to NNRTI will attenuate the activity of rilpivirine, and patients who have resistance would not necessarily be candidates, even if they're virally suppressed on another regimen, for switching over to injectables. That particular study has not yet been done, so I think that's a good point. So I think there was a comment about having a very young population. I think this would be a good approach for busy young patients. I think that's also an experience many of us agree with. Again, there is an effort looking specifically at these regimens, both for PrEP and for treatment in adolescents. And question about PrEP study, yes, that was Cabotegravir alone. So intramuscular Cabotegravir alone for PrEP compared to Tinofavir and FTC for PrEP. And it was actually superior to Tinofavir FTC in that setting. What about viral load restrictions, as with oral rilpivirine when paired with NRTIs? Right now, again, many of the clinical trials have gone with this oral lead-in phase. And you'll see when I show you the data from the clinical trials, patients had to have, if they were treatment naive, they had to have under 100,000 copies of virus to start in many of the clinical trials. So there were some viral load restrictions. And again, that's something to keep in mind with rilpivirine, because when you use rilpivirine in other regimens, that's one of the key features of the rilpivirine issue. Another comment, the most common NNRTI mutation at baseline is the K103N. This does not affect rilpivirine. Again, very good comment. You're correct about that. As long as there are no other NNRTI accompanying mutations, rilpivirine is still active in that singular mutation. And I think, okay, we're getting down to about our last 10 minutes here. Are there other topics or questions people want to talk about in terms of the challenges and potential for long-acting agents? I'm just flipping through for a moment the chat room. Lots of activity in the chat room. Thank you all. But making sure I've commented on everyone's points. What are the contraindications for this regimen? Well, I think the major contraindications we've talked a little bit about already would be people that you don't think will be able to comply with injections, people that may have baseline resistance, INSTI resistance, and NNRTI outside of just singular K103N resistance would not be candidates. But otherwise, I think these are pretty well tolerated agents. So I'm not sure that there would be other major contraindications. Obviously, there's a question here about pregnant women. It has not been studied extensively in pregnant women. So they may not be people that you would start immediately on an injectable agent, but getting them through the pregnancy and then moving on to an injectable agent after delivery. Are you giving Cabotegravir, rilpivirine at the same time as Depo Provera? I don't think anyone's ever addressed that in the context of clinical trials. I probably would not. Michael, you have your hand up. You have comments for us?
Well, it's a talk just briefly. You'll probably talk about it in your next talk, Dr. Benson, on the sub-Q capsid inhibitor. If you can, I know it's further down the road, but it's also another long-acting injectable that might be every 6 months based on the preliminary data, and it's very potent. And so that's exciting about the future.
Yes, you're giving a little preview of my next talk. So you heard a little bit about that in Dr. Gillick's talk as well. So I think that, and I'll just give you one of my summary comments as well. I think nearly every new drug that's in development right now is in development as either a long-acting or an injectable formulation that is long-acting. And I think this is clearly going to be an approach for the future for a lot of us. I think Christine comments about why not co-administer with Depo Provera. I don't really have anything other than sort of my own clinical comfort level to talk about. Just giving 2 injections at once sometimes makes some of our patients uncomfortable, but I don't think there's any particular pharmacokinetic reason why you couldn't give them co-administered. Maybe not, you wouldn't do it in the same arm or the same place, but certainly in the same visit. I don't think there's any contraindication to that. What about BMI as a factor with the dose? There was early on in the Latte and Atlas studies a concern about BMI resulting in lower concentrations in some people. As those studies moved on through their long-term follow-up, this didn't turn out to be a critical factor, but it may depend, it may be related more to where the injection was given and how much fatty tissue you had to get through to give the intramuscular injection more than the BMI in and of itself. So I don't think this has been clearly looked at in most of these clinical trials now, and it's not been associated with any difference in efficacy depending on BMI. But I think that will await FDA commentary. Any studies on drug interactions, hormone therapy, and caring for transgender men and women? I don't think this has been evaluated at all. The HPTN 083 study for PrEP did include transgender individuals in the trial, and I don't recall seeing any data on interactions with hormone therapies, but I also don't know if they excluded people who were still getting hormone therapy. Anyone else know that answer? Michael, you have your hand up still, or? you want to make another comment?
I'll hold for the moment.
Okay. All right. Depo Provera is even 3 months. Yeah, so you may not always be on the same schedule if you're giving Depo Provera and long-acting injectables. So that would be also something to consider about not giving them at the same time.
Dr. Benson?
Yeah.
Did we have any weight gain data on maintenance therapy with Cabotegravir out to 96 weeks? Is there any weight gain associated? They gone back and looked at that?
I'm sure they have, but I don't want to comment because I don't remember. So
just because it's such a hot topic right now. So
absolutely a hot topic,
especially maintenance therapy. If you're considering that, you want to have that all the information.
Yeah, and as I'm recalling, I was leading the DSMB for the Latte and Atlas trials, and I believe there was modest weight gain reported, but not in everybody. And I think it was kind of this sine wave distribution where some people had weight gain, some people lost weight, and some people had no change. But I don't recall in any of the data I've seen that it was a major consideration. And that may be related to Cabotegravir as opposed to dolutegravir and some of the other integrase inhibitors. So anyone else remember data about weight gain? Okay. All right, I think, any other questions or comments people want to finish with while we're our last few minutes? I think we're all excited about this new approach to therapy. We're excited to see it being used with these two agents, both for PrEP and for treatment, but also you'll be hearing about a lot of follow-on agents that I think are pretty exciting as well. I think we're moving into a new era in antiretroviral therapy that none of us probably imagined we would be at 35 years ago when some of us started working in HIV. And it's been a really tremendous evolution. I think figuring out exactly how to put all of this together for the best use for our patients and our clients in clinical practice is going to be a challenge for all of us. Just checking the last couple questions. Are we not using Taf or Tinofavir with Cabotegravir? Well, right now the clinical trials have not used Taf or Tinofavir, and trying to avoid some of the complications of Tinofavir. I think there's lots of room for additional work and challenges for additional research that needs to be done in using these agents, just like any new regimen that comes into clinical practice, how to use them with existing therapies, how to use them in the context of what we encounter in day-to-day living for patients. And I think, okay, so I'm just clarifying the TAF and TDF comment. They were talking about weight issues. Maybe we won't see as much weight gain with Cabotegravir and rilpivirine since we're not combining it with TAF. And that goes to some of the data you've seen presented or will see presented at this meeting on weight gain and the issue of TAF itself perhaps contributing to the weight gain that we see with integrase inhibitors. So that's a very astute comment as well. And resistance in studies on patients taking injectable Cabotegravir and rilpivirine. So the resistance data are really very compelling, meaning that we've seen very few people with resistance to either agent. But again, a lot of times in clinical trials where people are being monitored very carefully and we're picking things up early, you may see more resistance in clinical practice as you start to work with these agents. I think Cabotegravir is a very potent integrase inhibitor, and as you know, there's a very high barrier to development of resistance with Cabotegravir, and rilpivirine being an NNRTI, not so high, little more vulnerable in terms of a drug, but the combination of the two is really very potent, and I think we're unlikely to see huge issues with resistance if people are complying with the schedule for their injections, and we're seeing good response to therapy. But just like everything all of us have seen in clinical practice, resistance happens, and I expect that we'll see it with this regimen as well, but we're hoping that it won't be to the same degree. So I think we're going to have to wrap up and close now. We have a 15-minute break, I believe, before the next talk, which is me again. So you can either ignore it or you can tune in and listen to my next talk. But thank you all for your attention. You've had great comments, great questions, a lot of good discussion. You've even raised some points I hadn't thought about. So thank you for educating me as well. And we'll close the session now and enjoy the break and see you in a little bit.